All right. Well, we will get started here with our ultrasound case series for today. First, we want to start off with a plug for the AMSSM Library of Sports Ultrasound Pathology. So this is a collection of sports ultrasound pathologies housed on the AMSSM website. So any attending or trainee can submit cases for this. With high quality imaging. This can be common or rare pathologies. So it can be common things that we just want to build this library out. Cases are published on the website, and then this is something that you can add to your publications to your CV. So great opportunity, especially for trainees, to get another publication and add some stuff to the CV. So you can email the two attendings at the top of the screen here, or use the QR code for the library link to submit cases for this. So now we'll kind of transition. Today we're excited to have Matt Waldrop be presenting on knee lesion. So Matt is the current primary care sports medicine fellow at the University of Wisconsin-Madison. He did his residency training in family medicine at Wake Forest University. He also is helping out with the library, the case library. So he's somebody you can also reach out to if you have questions about that. So without further ado, I'll hand it over to Matt to present on knee lesion.
All right. Hi, everybody. I'm Matt Waldrop. I'm the primary care sports medicine fellow at UW-Madison this year, and we will go ahead and get started with this ultrasound case of a medial knee lesion. I've got no disclosures. So we will start with the case presentation, some scanning considerations, and ultrasound protocol for the medial knee. We'll then move on to the images themselves and the ultrasound report, and then we'll wrap things up with the outcome of the case, some take-home points, and any questions that you might have. So we have a 31-year-old female rugby player presenting 4 days with 4 days of acute right knee pain following a direct blow to the medial knee while being tackled. She endorses medial knee pain with associated swelling and local numbness and tingling only to the affected area. She has a history of an ACL tear status post reconstruction on the left side over 5 years ago. And she also has a history of a left knee Morel Lavallée lesion 5 years ago from a rugby injury that did resolve with conservative measures. On exam, she is 5 feet 2 inches tall, weighs 137 pounds, and her BMI is 25.5. Inspection is notable for significant ecchymosis over the medial knee with a large area of fluctuance, consistent with a possible fluid pocket, and there's no warmth or erythema present. She's tender to palpation over the medial femoral condyle and over the medial patellar facet. No range of motion deficits are present involving the right knee with active or passive range of motion, and no strength deficits are noted with resisted knee flexion or extension. Anterior, posterior drawer, Lockman, McMurray, and patellar compression testing are all negative, and then valgus and varus testing is stable at 0 and 30 degrees of flexion with no pain. So our initial differential is pretty broad, including MCL injury, medial femoral condyle fracture, MPFL ligament or MPFL injury, a medial meniscus injury, a large hamstring tear, a saphenous neuritis, and a Morel Lavallée lesion. Depending on the location of focus in the knee, there are a few positions to put the patient in that can really help as far as accessing and assessing specific regions and with dynamic examinations as well. One position, especially for identifying anterior knee structures, is having the patient supine with the knee slightly flexed. Putting a pillow or a rolled towel under the knee can be somewhat helpful for this as well. Having the patient lie in lateral decubitus position on the side of the leg of interest can be beneficial for evaluating structures of the medial aspect of that knee, just making sure the bottom knee is slightly more anterior than the top knee. And then having the patient lie prone with the end of their feet hanging off the table can be beneficial for evaluating the posterior knee, including potential aspiration and injection of a Baker cyst. And in most patients, we use a mid-frequency linear array transducer when assessing structures in the medial knee. So the required structures in the AMSSM ultrasound protocol for the medial knee includes the MCL with attention to the superficial and the deep portions of that ligament, as well as a cine clip including dynamic valgus force as indicated to evaluate for potential gapping. The medial tibiofemoral joint space, along with the anterior and posterior horns of the medial meniscus, the pes anserine tendons and bursa, the medial patellar retinaculum, the MPFL, and the medial patellofemoral joint. Optional structures in the medial knee include the saphenous nerve and the insertion of the semimembranosus tendon. And then other considerations, depending on the differential at the time of ultrasound evaluation, include the suprapatellar recess of the knee joint to assess for knee joint effusion and evaluation of the posterior aspect of the knee briefly to evaluate for a potential Baker cyst. Again, those are not specific in the medial knee ultrasound protocol. So here's the anatomy of the structures assessed within the medial knee that those watching later on YouTube can always refer back to as needed. All right, so we will start with our ultrasound images for this case. This is a long axis view of the suprapatellar recess of the knee joint. To find this view, you go long axis at the proximal aspect of the patella on the anterior aspect of the knee. Sometimes to evaluate for an actual fusion, you have to translate the transducer either medially or laterally to see if there's fluid potentially hiding in those recesses on the side. So you can see the quadriceps tendon running across the top of the screen and attaching distally on the superior pole of the patella on the right side of our screen here. The suprapatellar fat pad is located just inferior to the quadriceps tendon, and the suprapatellar recess you can see here has just a trace amount of fluid in it, which can be normal to have some physiologic fluid present. And deep to all that is the anterior aspect of the femur at the bottom of the screen. So this is a short axis view, if we rotate our transducer 90 degrees, just superior to the patella. And again, you can see the quadriceps tendon, a trace amount of fluid within the suprapatellar recess, suprapatellar fat pad, and the femur deep to all that. And again, this is a normal amount of physiologic fluid. So next we will move over to the medial side to assess the medial tibiofemoral joint space and the medial meniscus as well in short axis. It can be helpful to have the patient in that lateral decubitus position for this view on the side of the knee of interest on the bottom and slightly moving that knee slightly anterior to the top knee. And then the probe is placed longitudinally along the patient's medial knee. Here's the femur on the left, tibia is on the right. Top view is the more anterior aspect of the joint space where you can actually see the very outermost aspect of the anterior horn of the medial meniscus pretty darn well. The bottom image is the posterior aspect, and you can't quite see the outermost aspect of the posterior horn of the medial meniscus quite as well. It's worth noting ultrasound, not an extremely useful tool for evaluating the entire meniscus, as you can really only see the most superficial aspects of it. You can sometimes see perimeniscal cysts that can suggest meniscal tears, or in some cases, meniscal extrusion. But MRI is definitely the superior modality to diagnose meniscal tears. And then similarly, in folks with degenerative disease of their knee joint, you can sometimes see irregularity of the bony contours on ultrasound. But again, X-ray or even MRI sometimes are better for identifying these changes. You don't usually see knee joint effusions along the medial and lateral joint line. Those are better assessed looking at the suprapatellar recess anteriorly, like we just looked at, or even potentially evaluating for a possible Baker cyst posteriorly. And then for our patient specifically, this portion of the exam was normal. So turning the transducer 90 degrees, this is the medial meniscus and medial tibiofemoral joint space in short axis. Looking in between the femur and tibia, you can again see the outermost portion of the medial meniscus, but not often is there a lot to gain from this evaluation, and this would be considered normal again for our patient. So if we rotate our transducer back 90 degrees again, where we were when we were assessing that medial joint line in long axis and the meniscus, and then we translate the transducer superiorly, we can find the origin of the medial collateral ligament. And then if we translate distally, we can follow that MCL all the way down to its insertion on the tibia. It's worth noting that the MCL does attach pretty distal on the medial aspect of the tibia, so it's not really necessarily close to the joint line. So it feels like you're tracking it pretty far distally onto the insertion. When we are assessing the MCL, we evaluate the deep fibers that are only located proximal to the tibiofemoral joint and then attach to a portion of the medial meniscus. The superficial fibers, then we can assess, they travel distal to the tibiofemoral joint and attach to that medial aspect of the tibia, as you can see here, like we were discussing. Keep the bottom view in mind here. Keep that bottom view in mind for later. And when we evaluate the pes anserine tendons and bursa, as that will be kind of helpful, a helpful home base to find and rotate on those tendons as well. We can assess for evidence of hyperemia or neovascularization surrounding the MCL. That can be evidence of injury or suggest injury at times, but we don't see much of that here in our patient. And then we rotate our transducer 90 degrees again to evaluate the MCL in short axis, traveling from its origin on the femur to its insertion on the tibia. Can be a little harder to see in this view, but the MCL is there and considered normal in our patient. And then again, with power Doppler, we don't see any significant evidence of hyperemia. So we've got a little video here. One thing we can do is evaluate the integrity of the MCL is with dynamic stress testing. We do this by putting valgus force on the knee while evaluating the MCL and medial joint line in long axis, and that can help us evaluate for possible gapping of that tendon. If clinical suspicion is high, you may want to evaluate the ligament and long axis at multiple levels to fully assess the length of that MCL tendon. This was a normal examination of the MCL with normal dynamic MCL testing. One way I think can be helpful to find the pes anserine tendons and bursa is to find that MCL and long axis like we were talking about. I copy and pasted that bottom image from the long axis MCL evaluation at the bottom of the screen here. Eventually, you'll see a hypoechoic structure that it lies just superficial to the MCL, and those are the pes anserine tendons and bursa. The reason they're pretty hypoechoic initially is because the angle that you're viewing them is actually pretty oblique. So they do usually appear slightly anisotropic. And if you turn the proximal end of your transducer slightly more lateral, while keeping these structures centered, you'll be able to see them a little bit better in short axis and clear up that anisotropy. All right, so here are the pes anserine tendons and bursa. And now that we're more oblique on the MCL, that does appear slightly darker due to that anisotropy and is located just deep to the pes. If we rotate our transducer 90 degrees, we can evaluate the pes tendons in long axis and follow them to their insertion on the tibia. This also allows for a better view of assessing the pes bursa itself. Our patient didn't have any fluid present within their pes bursa. When evaluating this, it's important to remember to try to keep extremely light pressure on the transducer and maybe even float the transducer with a lot of gel, because sometimes even a small amount of pressure can cause any fluid in that bursa directly under the probe to disperse and then kind of miss that aspect of the fluid within the bursa. This was considered normal on our patient. There's some anisotropy at the distal most portion of the pes insertion on the right side of the screen that we definitely could have done a better job of brightening up by just kind of rocking our probe. That was corrected when we did that, but unfortunately we did catch it on imaging, but we did not deem this to be secondary to tendinopathic changes. No, next we will move just medial to the patella to assess the medial patellar retinaculum, the medial patellofemoral ligament, and the medial patellofemoral joint. Starting with our focus on the medial patellar retinaculum and long axis, we move distally down the medial aspect of the patella with our transducer transverse to the length of the leg. The patellar retinaculum is a pretty broad fibrous connective tissue structure, it includes the medial patellofemoral ligament as one small part of it, that expands from some of the quadriceps tendon, the femur, the meniscus as well to connect to the actual medial portion or aspect of the patella. The top image is the more proximal, and the bottom image is more distal, looking at that long axis view of the medial patellar retinaculum or MPR. The patella is on the right and the femur is on the left, and then with the MPR attaching at the medial aspect of the patella and traveling just superficial to the femur medially. Because this is a pretty darn broad structure, it can be hard to detect really small changes or tears in this. So definitely an area where power Doppler can help if there is a high index of suspicion of injury. And then rotating the transducer 90 degrees and following the MPR medially, we can evaluate this broad structure and more in short axis. You can see this a little bit better how broad the structure is just on this view. You can barely catch some of the superficial, most lateral fibers at the medial most portion of the patella on the left, so you can still really see the patella, and then some of those fibers that really are just either attached or like about to attach. This was considered normal in our patient. The medial patellofemoral ligament, or MPFL, is one of the medial patellar retinaculum, or one part of the medial patellar retinaculum, and it connects the medial aspect of the patella to the medial femur between the adductor tubercle and the medial femoral epicondyle. You can find this structure going back to the long axis view of that MPR and translating distally and proximally with the medial aspect of the patella on your screen to find this smaller band-like structure extending medially. You can follow this all the way out to the medial aspect of the femur. If you're superior enough on it, you can catch the part of the adductor, a part of the adductor magnus tendon as well, as these two attach pretty close together along that medial aspect of the distal femur. And then again, you can evaluate this area with power Doppler if you're concerned for injury, and this was considered a normal exam in our patient. The structure can be difficult to see in short axis as it can get pretty lost within that broad MPR. But if you do rotate that transducer 90 degrees again, when you're evaluating that MPFL in long axis, then you can find it in short axis, just keeping it in the middle of your screen. And then you can again follow it medially to its insertion. And in our patient, this was considered a normal exam. Saphenous nerve is an optional structure to evaluate in the medial knee. It's easiest to find in short axis, starting more proximally along the medial aspect of the thigh and then translating distally. Translating the transducer kind of proximally and distally a little bit more quickly can actually help nerves stick out a little bit more or help you identify them along its course. Makes it a little bit easier to track when you're really trying to differentiate, is this just part of the fascial plane or is this an actual nerve I'm trying to identify? The saphenous nerve typically travels alongside the femoral artery and vein at this level, and those can also be helpful home bases. So moving from left to right and then down on the screen correlates with translating the transducer proximally to distally. The sartorius muscle belly is located posterior and the vastus medialis is anterior to the saphenous nerve. And then as you move distally, you can follow that nerve in the fascial plane between those two. If indicated, you can evaluate the suprapatellar and infrapatellar branches of the saphenous nerve, and then you can also follow the nerve down to the level of the medial femoral condyle and even further distally as needed. This was considered a normal exam again for our patient. If you find the saphenous nerve in short axis, you can turn 90 degrees on it and you can evaluate that nerve in long axis. This can be helpful if you're concerned for areas of compression where you can measure the diameter of the nerve and even compare to the contralateral side as well. This was considered a normal exam again in our patient. So Baker cyst evaluation in the posterior knee, again, is not part of that medial knee protocol, but it can be helpful when you are evaluating swelling about the knee, such as in our patient. Evaluation of this region usually works best with the patient lying prone with their feet hanging off the end of the table. And then going short axis over the posterior aspect of the knee joint with the transducer is typically a good starting place for this evaluation. There you go. Looking first in short axis on the left side of that screen, the important structures defined in this evaluation is the medial head of the gastrocnemius and the semimembranosus tendon. The pathognomonic findings of Baker's cysts that before you ever stick a needle in it. You have to identify to ensure it truly is a Baker's cyst and not like a weird arterial aneurysm or a mass lesion, is seeing that neck of the Baker's cyst extending from the tibiofemoral joint space posteriorly between the medial head of the gastrocnemius and the semimembranosus tendon. You can also catch the semitendinosus tendon just superficial to that semimembranosus tendon in this view. And then if you rotate the transducer 90 degrees, you can evaluate this in long axis as well, with the medial head of the gastrocnemius on the right side. Again, considered a normal exam in our patient. This is just an example of what a Baker's cyst would look like. This is not our patient, but really just wanted to emphasize, you could see on the left side of the screen in short axis, that neck of the Baker's cyst extending between the medial head of the gastroc and the semimembranosus tendon. All right, the semimembranosus tendon insertion is another optional structure in the medial knee ultrasound protocol for AMSSM. It attaches at the posterior aspect of the medial tibial condyle, and it's usually easiest to visualize with the patient supine and then finding the semimembranosus tendon in short axis. It's like probably more prone than supine. Might be hard to evaluate supine. Um, this tendon typically courses slightly medially, so it can be helpful to turn your transducer a few degrees to better evaluate the tendon fibers. But you can find this semimembranosus tendon in short axis just like we saw it kind of when we were evaluating the Baker's cyst. That's another easy home base. The semimembranosus tendon is again deep to that semitendinosus tendon, and as you follow it more distally, you'll actually lose that semitendinosus tendon as it courses more anteriorly as part of that pes anserinus. And then we can follow the semimembranosus tendon in short axis as it moves through that popliteal fossa and then attaches on the posterior aspect of the medial tibial condyle. This was again was considered normal in our patient. Again, the image on the bottom right had a little more anisotropy than we would have liked to capture, but toggling our transducer, the tendon did appear normal that we unfortunately did not capture super well on imaging. And then again, rotating the transducer 90 degrees, we can evaluate that semimembranosus tendon in long axis down to its insertion on the tibia. And again, normal in our patient, dark area on our patient was more anisotropy and did not represent true fluid. All right, now the interesting stuff. Moving on to our pathology. So we had to use an extended view to capture the entire area. So it allowed us to follow the entire course of our lesion and measure that distance both longitudinally and transversely. Here we started at the posterior most aspect of the lesion, and then we moved our transducer anteriorly to capture the entirety of the lesion in short axis. And then here we can identify this Morel-Lavallée lesion located between the skin and superficial fat and then the fascia and deep fat. Anteriorly, we can see the patellar tendon and medial aspect of the tibia in the elongated view. And then this lesion measured approximately 10.5 centimeters in AP diameter. All right, rotating that transducer 90 degrees again, we found the longest part of the lesion from proximal to distal, and with that same elongated view, allowed us to capture the entire length of that lesion. Here it measured approximately 14.7 centimeters in diameter from proximal to distal, with the same evidence of the Morel-Lavallée lesion between the skin and superficial fat and the fascia and deep fat. Here is a brief image of the lesion in long axis with power Doppler, just demonstrating an absence of any flow. And then this here started is a cine view or a video of that Morel-Lavallée lesion from proximal to distal, just kind of traveling or translating down that lesion in short axis. Good. All right, so moving on to our complete diagnostic ultrasound report of the right medial knee in this patient. Our indication was swelling and pain of the right medial knee. The patient was examined in supine position, right lateral decubitus position, and prone position with a 4 to 12 megahertz linear array transducer. All of our findings were reported as normal until we reached the other section of the report, where we noted a large hypoechoic fluid collection deep to the subcutaneous tissue, but superficial to the muscle fascia, deep fatty tissue, and knee joint. The lesion is without septations. It's consistently hypoechoic and measured approximately 10.5 centimeters in AP to 14 point centimeters from proximal to distal. So our impression was a large Morel-Lavallée lesion measuring approximately 10.5 centimeters anterior to posterior by approximately 14.7 centimeters proximal to distal, overlying the right medial knee. This is just a correlating MRI for our patient with the coronal PD fat suppressed image on the left, showing that extent of the length of the lesion. And then the axial reformat view on the right shows a good view of kind of that width of the lesion. So outcome, 170 cc's of fluid was aspirated from the lesion 17 days after the initial injury, and that was followed by a corticosteroid injection at the time. 3 months later, unfortunately, that lesion recurred, and this time it measured approximately 5.7 centimeters AP by 7.6 centimeters proximal to distal. Lesion was re-aspirated, this time only yielding 10 cc's of fluid, and steroid injection was repeated. So she attempted return to sport 4 months after that, and after her symptoms had improved and pretty much resolved, but the lesion unfortunately recurred a third time, this time measuring 7.2 centimeters anterior to posterior and approximately 6.4 proximal to distal. So this time, 37 cc's of fluid was aspirated from the lesion, and instead of a third injection of steroid, this time doxycycline sclerodesis was performed. This has some level 4 evidence in support of it for recurrent lesions refractory to steroid injection or other conservative measures. This is an extremely painful procedure, both during the procedure itself and also afterwards, because what you're essentially doing is trying to get the tissue itself basically to scar itself down. Unfortunately, despite the repeated aspiration with steroid injection and the trial of the doxycycline sclerodesis, it did recur 2 months later. And at that point, we were nearing a year after the initial injury itself. So she ended up seeing one of our surgical colleagues who did an open surgical resection of the lesion with a temporary drain replacement. She's actually now doing well about 4 months post-op and has not had a recurrence of the lesion. She is also undergoing a workup for a connective tissue disorder just because of the recurrent nature of the lesion, history of a Morel-Lavallée lesion on the contralateral side years ago that resolved with conservative measures. But in the meantime, she has just recently returned to playing rugby, and so far, so good. So some take-home points from this case and the overview of the medial knee ultrasound protocol with AMSSM. The MCL travels further distal than most people think, and it inserts on at or when it inserts on the medial tibia. Meniscus evaluations with ultrasound are pretty limited because we can really only reliably visualize the external-most aspects of the anterior and posterior horns of the menisci. But we can sometimes see evidence of perimeniscal cysts or significant meniscal extrusion. Make sure you float the transducer when evaluating the pes bursa to avoid dispersing the fluid with pressure, and that really goes for any sort of superficial fluid collection that you're trying to assess. And if you're ever concerned about subtle pathology, always compare it to the contralateral side. When evaluating for Baker's cysts, make sure you're seeing the neck of the cyst between the medial head of the gastroc and the semimembranosus tendon. And then finally, Morel-Lavallée lesions are closed traumatic degloving injuries between the subcutaneous tissue and underlying fascia that create a potential space that can fill with blood, lymph, or necrotic fat. And then doxycycline sclerodesis has some level 4 evidence in the form of some case series for recurrent lesions refractory to conservative measures and corticosteroid injections. But keep in mind, it can be extremely painful and is not a fun procedure for patients to go through. So I would like to thank Dr. Erin Hammer for her help, not only with this case, but all of her teaching throughout fellowship this year. She's been an excellent mentor, and I'm very lucky to have the opportunity to work with her. And along that note, I'd like to thank the entire EW Primary Care Sports Medicine Fellowship and all my attendings for just an outstanding fellowship experience. Here are my references, and I will take any questions you might have.
All right. Well, thank you so much, Matt. Obviously, that was a great presentation, going over an area when we're talking about, knee lesions. that can have a very, broad differential. So coming up with a systematic protocol and kind of including all the differential diagnosis in that is extremely important. One thing I was going to add, for the protocol in this area, that sometimes I'll do depending on the patient presentation is well is going to be the pre-patellar bursa. I've
Mhm.
just been surprised, obviously sometimes with trauma in that area that those can become, very large and distended, and especially, where they're occurring as well too. Sometimes definitely can track more, medially. Sometimes they can be more laterally. Sometimes they can be distal, as well too. But I typically will include that in the protocol as well too. But as you had mentioned, for that area, it's going to be very key, light transducer pressure as you're going over it, but something to kind of include in that differential. And then two other things you had covered the areas, but just had mentioned as potential diagnoses that you can also see. You had mentioned with the MCL, of course, you can have sprains and tears in that area, but you can actually get bursitis or bursal distension as well too, typically along that proximal aspect, and that's known as Voschel's, bursitis. So something to keep in that. And then the other, you had covered the meniscus, and we'd covered this in other AMSSM ultrasound case series presentations as well too. Just knowing that you can get perimeniscal cysts in that region too that can actually become very large. They can become multiloculated. So, being aware that those can occur. But as you had mentioned, one thing to kind of really easy to differentiate that is going to be based on the location of the fluid. Is it going to be in the superficial tissue versus obviously, is it going to be extravasating from the joint line, and then also compressibility for that. With the cyst, those are not going to be compressible, whereas any of the soft tissue, fluid collections, as you had mentioned, are going to be compressible. So those are the major comments that I had to have. We had one question about the case that said, would you routinely get an MRI in these cases, or was there something else on the physical exam that caused you to get that?
That's a good question. That actually, the MRI had been obtained prior to the patient having seen us. I I think the thought process at the time was that when they had seen the sports med physician in clinic, as far as like for diagnostic utility at that time, it was probably a little bit quicker to get that MRI than it was to get a diagnostic ultrasound. So that's probably the thought process that went into it before they kind of got sent over to us to actually get it, the lesion aspirated and injected. So unfortunately, we weren't there at the initial point of contact with that patient. But, I think that's what we're thinking about is that, if this is pretty consistent with the Morel lavellate lesion on ultrasound and MRI, like a correlating MRI is definitely not necessarily needed.
Yeah, and I think we've talked a little bit too in previous cases for the knee. I think one thing, as you included in your protocol, is to be looking at that suprapatellar recess, because obviously if you start to see fluid in that area, you of course would start to be concerned that even if they have this Morel-Lavallée lesion, do they have concurrent intra-articular, pathology, which of course would lead you to still go ahead and get the MRI in those cases, just so you could evaluate further intra-articularly for any pathology.
This is Doug Hoffman. Really nice presentation and review of the medial knee structures. Yeah, I was going to sort of piggyback what Dr. Schaff just said. I mean, in the setting of first doing an ultrasound, if you did not see a knee effusion, would you be comfortable, and saw a Morale-Lavallée lesion, would you be comfortable proceeding from there, or would people feel like, okay, let's still get an MR? Good question. Um, I think I probably would, if the person responded appropriately to treatment of the Morale Lavalley and had no evidence of a knee effusion on ultrasound, I might feel comfortable in the right setting, but certainly I see both ways. I know in our department, we've instructed our sports med docs that, if they suspect a Morale Lavalley lesion to refer as soon as possible. And what we've been doing is just serial aspirations. And with some success if you get to them right away. So my routine is I'll aspirate the fluid, seen them back in 10 days. They usually still have fluid, but if we do these serial aspirations and each time we get less and less, we've had some success with that, understanding that in any treatment modalities, these can be hard. And we typically haven't put steroid in. I'm interested with others. Do you routinely put a steroid in a Morale Lavallée lesion or not? But that's kind of been our routine is to do these serial aspirations and see if we can get this to sort of natively scross down. So again, I typically don't use a steroid, but I'm interested to know what other people are doing.
I think, yeah, on the chat that said that this was from South Alabama, that they just typically do serial aspirations. And then I know John Mason, if you're on the call, you had your hand raised. I don't know whether it was to comment on that or another question.
Yeah, hey, this is John Mason. Nice job, Matt. Yeah, it was to comment on our protocol. So at UT in Austin, what we are doing for lesions that are less than 50 cc's, we'll go ahead and just aspirate, and we won't do a corticosteroid injection. We found that when it's greater than 50 cc's, there's that paper that shows that there's about an 83% recurrence. So like Doug said, if we catch him early, we'll try to bring him back quickly for a serial drain without corticosteroid. But if it's a more chronic, long-standing issue and it's greater than 50 cc's, we just send them straight to surgery to have a drain put in.
Thanks, John. Good to see you.
Hey, Doug and Stephen and Matt, good job on this. A couple of thoughts. One, Doug, we do the same thing. We do serial aspiration. Um, and usually I do every week, and so I just bring them back every 7 days. And as long as the size continues to decrease from week to week, we'll continue with serial aspirations um, instead of instead of getting a little more invasive. That 50 mil paper came out of our trauma colleagues here at Mayo, saying that if it's greater than 50, it may not respond. I think our practice has changed since that was published, a decade ago. And in here, we tend to just aspirate, 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 as long as it continues to get better. And for larger ones, we will jump pretty quickly to doxycycline sclerosis. We never do corticosteroids into Morale Lavallée lesions. I'm not really sure I would understand like um, the rationale of it, other than maybe for pain. Doug, you mentioned getting these in really quickly, and I think that's important. I don't know if you scan these, chronically, you'll see that there's basically like this almost like a rind around the Morale Lavalley. And if you talk to people who are doing surgery on these, the inside of that is like very smooth, kind of slippery sort of surface and doesn't want to tack well together. And so the quicker you can get these collapse on each other, I think the better. And then as far as the doxycycline sclerosis goes, I do it a little bit differently than I think it's published in literature where people just inject it and go. I inject it and I let it sit for about an hour, and then I actually aspirate it. And then we're really big on compression and immobilization following any of these aspiration procedures, and in particular around the knee. So this is one of the few circumstances where I actually will put someone in a knee immobilizer. And the reason is we want those tissue planes to scar together. We don't want them to slide relative to one another. So I think immobilization and a lot of compression after these is really important. And then the second thing I was going to mention is, you mentioned that ultrasound of the meniscus is pretty limited. There's actually a lot of really good research on ultrasound of the meniscus, and so I'd encourage you to just take a look at some of that as far as some of the different signs that you can see that would suggest different meniscal pathologies within the knee. There's some pretty good rationale that this is a reasonable first step screening. Now, if you can get an MRI faster than ultrasound, certainly an MRI has a more conclusive finding. And if you're thinking it's a surgical meniscus problem, that's certainly a different story. But MRI and ultrasound actually show comparable diagnostic rates in certain conditions. So, just one more thought.
Thank you.
Yeah, thanks, Brennan. And just to piggyback that, going back to the Morale Lavallée, I've learned over time that even if the patient is successful in not having symptoms, sometimes you still see a very small amount of fluid there for months. And in fact, I've even looked at these a few years down the line, and I haven't necessarily seen fluid, but I've seen a cleavage plane that persists, obviously, in the fat, subcutaneous fat. And so, for me at least, if the patient is completely asymptomatic and they are not accumulating fluid with activity, then I find that successful because I don't really think we get to sonographic resolution of that cleavage plane, and a tiny bit of fluid is not unusual. And I do the same thing, Brendan, that you do is we're pretty careful on compression afterwards of these for that reason that you talk about. Um, Funny, the next thing on my list was, and again, this is probably a different topic, but is this dynamic maneuvers with the medial meniscus, which can potentially make a meniscal tear more conspicuous. Um, so that's what I had on my list. But yeah, this is good case and good discussion in terms of treatment because these are hard. And if I were to see a subacute or more of a chronic Morale-Lavallée, and I saw that almost capsule, so to speak, or a thickening, um, I, I would almost, I might try an aspiration, but at that point, I don't think we're going to be successful. I think if you don't get these soon enough and you already see thickening around or this capsule develop, then it's unlikely to be successful.
All right. Well, all great discussion there. I don't see any other questions or anything in the chat. So I think that will conclude today's ultrasound case series presentation. So once again, thank you, Matt.
Thanks, everybody.